Welcome to the Pod Doctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we are going to do a quick show addressing some questions from one of our subscribers regarding the bunion episode that we did, or we've done a couple of them.
Yeah, they were interested in, we talked about the osseous component of bunions, but they were like, hey, what we talked about, besides, shifting the bone over and putting screws and plates and stuff in there, what else do you guys do as far as treatment for the bunion? And, it's not just literally, it's not woodworking, but it is kind of a balancing act. Mm-hmm. So let's kind of dive into more than your basic bunion procedures. So just a recap, bunion is not a growth or a tumor. It's an angulation of your first metatarsal bone. It deviates over immediately towards the center of your body, and over time it can become painful and arthritic, and that's usually why we go in to fix them. Imaging, kind of a little guideline. This is the first metatarsal. It'll show you over, and what we're going in to do is shift that first metatarsal back over towards the second metatarsal, so it's back in alignment. That phalanx is now gliding smoothly over the articular surface rather than half articular, half bone, as you can kind of see here.
And that's a great picture showing relatively normal intermetatarsal angle between the first and second metatarsals versus a severe bunion at 19 degrees. So 7 to 10, you're not going to have too much trouble. As soon as you start getting up there into the high
double
teens,
digits,
man, 19, 20, 21 degrees. And then you see the hallux abductus angle, which is that further down angle, 37 degrees.
Yeah.
You've uncovered 50% of the cartilage. Now that cartilage is getting worn away by the joint capsule. So yeah, that's a mess. That's a very difficult bunion, and I would suspect that has a highly hypermobile aspect to it, which that's a lapidus written all over it for me.
So, as far as basic bunions go, most of these procedures that we do are very simple Austin-Aiken type procedures. The Austin bunionectomy is probably the most common of all bunion procedures. We literally go in, we do a chevron type cut, and we shift it over. Fixating with screws, K-wires, staples. I know people use a lot of things. I'm more of a screw guy. I think most people do screws.
Yeah.
The classic Austin, this is the Kalish modification. The classic Austin was more of a short chevron type cut, and you only did one type of screw or secluded K-wires or absorbable pins or a lot of fun stuff. The Aiken, the adjunct to most type of bunion procedures, is the phalanx osteotomy across the proximal phalanx. We do a wedge type cut to shift over that phalanx to come back in alignment, because sometimes you'll drift over that metatarsal head back to where it's supposed to be, but you'll still have that angulation, that deviation of that toe, and that Aiken osteotomy will help bring that back over. And sometimes the deformity will be in the phalanx and not in the metatarsal itself. So here are a couple of depictions of different ways that they fix the bunions and the Aiken deformities. And we talked about this.
The Aiken is great, and I think I do them, I would say 98% of the time. Yeah. I mean, it's just a small percentage where you're looking at that toe in the OR and you're like, just doesn't need it. It's perfect. And, the enemy of good is better in the OR. But man, when you don't do them and the patient needed it. You see them a couple weeks
later and you kind of see that little drift over.
You're just like, oh. So, yeah, my first couple of years in practice, I didn't do as many of them as I do now. And I ended up having to go back in and fix those.
Yeah. And a lot of people depend on the soft tissue component, which we're going to get into.
Right.
And they try to depend on that soft tissue component. But that soft tissue, you got to remember, it's tissue.
If you don't fix the bony aspect well the first time, all the soft tissue correction in the world, it's probably not going to make up for that.
Yeah.
So soft tissue is an adjunct.
So
go back real quick. I wanted to mention, so the bottom left-hand one, that's really a deformity of the interphalangeal joint itself.
Yeah, so they would do a distal Aiken.
Or you could even fuse that.
Yeah.
Yeah, you could. That joint's not critical, and fusing it actually can help stabilize the toe and really swing that thing over. But yeah, you could go either route. But that you've got a significant joint deviation there. You're not going to be able to fix that with soft tissue correction.
So incision placement. One of the big things that we've noticed over time is that different specialties that do foot and ankle surgery do different incision placements. So let's talk about why we do different incision placements. The classically, as far as foot and ankle surgeons that are trained specifically podiatrically, we'll do our incisions dorsomedially. Other specialties that do foot and ankle surgery that haven't specialized in foot and ankle surgery, I've noticed that I've worked with orthopods, they've done foot and ankle fellowships, and they'll do their incision dorsomedially. But other specialties that'll do foot and ankle surgery, like gen surge, ortho, that are not foot and ankle specific, they kind of rely on that medial incision. And we've fallen out of favor using that type of incision for the simple reason that your medial dorsocutaneous nerve crosses that area. Not to say that it can't cross up more superficially, but more often than not, you're at risk of catching that medial dorsocutaneous nerve as it kind of pinches across that area, across that medial bunion bump. And that's kind of one of the reasons that you have so much pain with a bunion in shoe gear. Some patients will radiate pain down to their toes, and the burning, tingling, it just aches after a busy day of wearing shoes. But when I take my shoes off, it's not that bad. Also, you'll have scar pain along that medial bump there. Also.
I would say I'd probably kind of fall somewhere in between. Yeah,
this is an over exaggeration. Yeah. Mine is probably more like this, where it's just on that medial curvature. But that's kind of the logic, and there's different variations and there's different values to this too. So sometimes if you have to do a sesamoid excision, a more medial based incision, letting patients know, look, there's a risk, with scar pain and nerve pain along the side, but usually we're able to take care and avoid that kind of stuff. Most surgeons will not have any complications, but why increase your risk when you can avoid it? But when you're trying to get the sesamoids out, or you're trying to do different type of procedures, the medial incision does help out. And sometimes they'll do the medial incision and they'll add a second incision up on top in that first interspace, where they can do that lateral release. And we'll talk about what that lateral release is in a second. So once we do the incision, this is incision, they'll do their capsulotomies. So there's a dozen different ways to do capsulotomies. So let's kind of dive into some of the most popular incisions. The medial vertical, not one of my favorite incisions. You're at risk of catching that nerve. You're not getting great exposure. I kind of fall into that T type of incision. I do either the straight incision, where you do your normal capsulotomy to kind of expose it, and then I'll do like the T to kind of help anchor, pull that hallux back over. So we're looking at the foot medially. We're looking at it from the side view. So when we're doing these capsulotomies, we're doing right along the side here, and that T will form, crossing that metatarsal to that phalanx, and that T will fall right into that joint space. There's people that do ellipticals and Washington monuments and inverted L. I've seen a lot of docs use that type of incision, and it's per person, honestly. It's whatever's good in your hands. The Washington monument is just kind of popular because you can use that extra strip to help hold that correction. And that's kind of when you kind of fall into that trap where you're like, do I want to use the soft tissue correction, or do I want to rely more on the bony correction, that Aiken, to help hold that correction in place? What do you think?
Yeah, I just do a straight line. I honestly don't rely on the capsulotomy to accomplish a whole lot. I think I'm aggressive with my bony correction, and I don't need it. I think all of these were designed during an era when very few of these were done in the hospital or surgery centers. They were done in the office. Yeah. And you maybe couldn't be quite as aggressive because they weren't using fixation. So,
and the appropriate fixation techniques weren't out there.
I know.
Staples,
it's crazy.
Tiny screws.
All of these capsulotomies were designed and discussed and written about decades ago. I mean, we're talking 60, 70, 80, 100 years ago. So, I just don't rely on them. So I just do a straight line. Yeah. But I like the T. If I was gonna do one that I really thought you needed to do the capsular correction, I would do the T all day long.
So sometimes you'll also have a bursa along that medial aspect. It's an area of pain and tenderness. It rubs against the shoe. So an adventitious bursa will form sometimes, and it can be extremely tender. Sometimes the patient will be like, I'm positive it's not a bunion. I could feel it move. It's soft. I think it's a ganglion or whatever it might be, and it's most likely the adventitious bursa forming because that bunion is pushing against that shoe gear or whatever it's pressing against. Sometimes if you're you're meticulous enough, you can take those out. Usually, once you do the bunion surgery, and obviously when you're in there, you can excise all that stuff out. That bursa pretty much dissipates or goes away. And,
if it's not under the continued pressure and friction, then it typically doesn't stick around.
Yeah, but these can be very tender.
Yeah, I would, if I saw one that size, I would take it out.
Yeah,
for sure.
All right, the lateral release. So this is something that we classically do along with our bunion procedures. We'll go in. So let's talk about what's happening with a bunion. Your musculoskeletal system is pulling that toe back towards you. The abductor hallucis is pulling it medially, right? Here, let's show it here. The abductor hallucis is pulling it medially, and your adductor hallucis is pulling it laterally. Now, if you can imagine, the one that's pulling back, the abductor, is pulling it more straight back and slightly medial. The adductor, the adductor hallucis, is pulling it more on a 45-degree angle, and that's why it becomes advantageous for that toe drift over.
It can laterally overpower and
and that's why your bunions form one direction more than another. So when we go in and we're talking about doing our lateral release, there's different variations of it, but most people will go in classically, release the sesamoidal ligaments, release the capsule, and release the adductor completely. The adductor inserts onto the sesamoids, so you can kind of see them here, and that base of that proximal phalanx. So most people release it right back here at the sesamoid level and free up any strands or branches that are going to the proximal phalanx, and you'll feel a great bit of mobility after you release that toe.
So I would say in the severe bunion, like in your picture, and when you have a sesamoidal view preoperatively showing that the sesamoids are dislocated, that's when I would do stuff like that. Mm-hmm. But the standard bunion that's a mild to moderate that you're operating on, if you look at the sesamoidal view and the sesamoids are still sitting in the cristae, or sitting on either side of the cristae, and it's just rotated. Exactly. So I don't know that you need an adductor release for that. If we're going to get into the weeds here, I think you need to do the right bone procedure to move the head over.
To shift that metatarsal.
And the reason I say that is because we actually did this study when I was a resident with Jeff Boberg, where we looked at AP views and axial sesamoid views before and after bunion surgeries, and it didn't matter if we did the adductor release. What mattered was you needed to move the head back over the sesamoids.
And that's what we're driving in.
Right.
The bony component is the most important.
It's really important.
All these soft tissue components are great adjuncts, but they're not going to fix the bunion.
So if the moral of the story was, if you're determining whether or not you need an adductor release and you're using an AP view, you're going to get fooled every time. So that's why that axial sesamoid view, which gives you this view that we're seeing on an X-ray, can tell you, okay, are those sesamoids dislocated? And if they are, then I think it's important to do that to kind of meet it halfway. You're moving the bone over, and you're letting the sesamoids, hopefully rock back under. So just something to consider for any of the podiatric residents out there. I think that you can prove it to yourself. Just take axial sesamoids on all your bunion patients instead of an oblique. I don't even know why you take an oblique on those preoperatively, because I don't think the oblique view does anything to help you. Yeah. But I think an AP, a lateral, and an axial sesamoid view for pre-op bunion patients is really, really helpful.
Yeah. So this kind of go into the specifics of the lateral release, the capsule, the ligaments, and then the adductor coming across here.
That's the other thing is I do these intracapsularly with the McGlamory. So if I'm going to do that, I'll just, and I can take that whole thing right off the base, and it accomplishes the same thing without making a secondary incision.
What about the adductor? How do you release the adductor from
Well, you're releasing that whole part of the capsule, so it's gone. Now, if I want to release the sesamoids, and I'm really concerned about that, then I do have to go in and do that. Okay. Yeah. Okay. But I can also do that I can do it intra-articularly.
Yeah.
It's a little trickier.
That's the difference of the incision placements.
Yeah.
So here's something I do, just because I was trained to do it with Dr. Millay. Shout out Dr. Millay. Where you do the adductor tendon transfer. So rather than releasing it, we do release it, but rather than leaving it kind of floating willy-nilly, we will take that adductor and we'll transfer it over to the head of the metatarsal. So I typically do this at the end of the bunion procedure. Bunion is corrected. The metatarsal is sitting over the sesamoids now. The adductor tendon transfer is not really specifically to help bring the sesamoids over, but more specifically to help make sure that the bunion doesn't reform again.
Yeah,
so you take that adductor.
You're turning a deforming force into a correcting force.
Yeah, exactly.
Absolutely.
Yeah. And I tell patients this, look, it takes an extra, 10, 15 minutes. Understand that the chance of this bunion returning is much, much lower. So the bunion, you have frontal plane rotation. So what we do is we take advantage of the shape of the bunion, the metatarsal, and we take that adductor, we bring it under the extensor tendon, and we tag it to the capsule and or the sesamoidal ligaments. So we're physically going to help bring the sesamoids back under, and you're going to hold that correction a lot longer and prevent that rotation from causing any further problems. And it works in my hands, and some people like it, some people don't. It's just everyone has their bag of tricks. As long as it works, stick to what works. Some docs do the minimally invasive surgery. I absolutely, I'm
not a big fan.
Yeah, not my fan. Not my bag of tricks. But if it works in their hands, by all means, there's more than one way to skin a cat type of logic. Oh, suture buttons. All right. So there was a time where
these were extremely popular.
Super popular because it was quick, it was easy. You pretty much so what it is, the suture button. There was a couple companies like Tightrope and I don't know whatever other companies. I'm not going to name companies. But the suture button technique was popular because you literally put 1 or 2 holes in the metatarsal and you crank it over. Real small incision. You literally tease until you find that sweet spot and do the adjustment. And yes, on X-ray it looked good. Yes, it reduced that bunion, but all of a sudden we started getting all of these stress fractures.
Second metatarsal fractures. And
yes, and
look at all that fun.
It kind of fell out of favor. Now, if you want to do that with a Lapidus or a closing base wedge or whatever other type of procedure, there's tons of papers that show that to be functional. But for people who solely rely on this, there's so much data out there that's shown that these kind of fail. But I'm not trying to talk down on other people. Do your research. There was a couple of papers that said instead of using the single suture button, switch to 3 suture buttons and stuff like that. Which I was like, all right. I mean, I guess to understand the logic.
Forces at any one spot. Yeah, but look at that.
Instead of putting it
2 and use
instead of putting in the second metatarsal, swing it through the second metatarsal to the third metatarsal. I don't know. Those metatarsals aren't meant to take that load at that shaft level.
Yeah.
They're meant to take that pressure load from the plantar surface. They're thin bones, not my
and
go-to.
The fracture. I mean, just the pictures on the left. I mean, you even worry about that second metatarsal phalangeal joint subluxed. Like it was subluxed immediately after surgery, and it's really subluxed after the metatarsal fractures. Yeah. So that's a missed opportunity there, possibly as well.
So the final thing, extensor lengthening. So sometimes we'll do the bunion correction, and since the bunion has been deformed for so long, that first metatarsal is deviated, that toe has been angulated in, that phalanx structure has been angulated in. The extensor tendons are now very tight because now they're used to being in that short position. So when you finally bring it back over and get this back under alignment, the extensor tendon or the flexor tendon, most commonly the extensor tendon, has tightness and is cranking back on that toe. The toe is sitting up or angled or it's not sitting appropriately. So we'll talk about doing some type of extensor lengthening. Now there's multiple ways of lengthening these tendons. Most commonly people will do like a Z lengthening. They'll go in, they'll split the tendons. The extensor hallucis is usually the one, the extensor hallucis longest is usually the one that's the most tight out of both of them. So most people will lengthen the extensor hallucis if they feel a need. Some people will do both per person and per case, honestly. There's different ways to lengthen it. Some people do the Z lengthening, some people do the triple hemisection type of lengthenings. Some people will put a graft or a synthetic graft in there. Some people will tag both the tendons together and lengthen one and lengthen the other so they can kind of meet weight halfway in the middle. I don't know. There's a different.
I think you got to be careful here. If you're using an ankle tourniquet, you really don't want to be extensor tendon lengthening.
That's a good point.
Because your ankle tourniquet, which we, almost invariably use, unless I'm doing a Lapidus, I'll use an ankle tourniquet. Yeah. You're going to see tension on that tendon that's not really there physiologically. Yeah. And suddenly you think, oh, I got to lengthen this tendon. And you take the tourniquet off, and suddenly the big toe's like,
sits down.
So I would say I used to do a lot more of these when I was first in practice, and I don't do them virtually ever now.
Yeah, it's very rare. That's why
because you're shortening the bone. When you're doing a typical bunion surgery, you're probably shortening the bone 4 millimeters just based on bone cuts. Yeah. So that's going to lengthen that tendon physiologically by shortening the bone. So I've gone way to the other extreme on this. But there are some where it was such a severe bunion.
They'll have that contracture to them. Yeah.
There was some that it was such a severe bunion before. Now it's straight. And suddenly this tendon is way short. So those are the ones where I'll at least consider it. Like you got a 21, 22 degree IM angle. The toe is like, yeah. Those, I can see that. We're getting into the minutia again, but yeah, I think that's a procedure that I don't think the vast majority of bunion surgeries need, but those really severe ones, you want to consider it.
Yeah. Well, I mean, as far as adjunct procedures with bunions go, that's pretty much it. I'm sure there's a lot of other small stuff that we can dive into, but
I think that hopefully answers the question of one of our subscribers who was asking specifically about that. So hopefully you're still a subscriber and you're still watching, and that answered your questions about some of the soft tissue and adjunctive things that we do for bunions that we may have glossed over on the original bunion surgery episode. So awesome. Thanks, Dr. Hussain. That was a good 22 minutes of adjunctive bunion procedures. So I hope you guys got something out of that, and we will see you next time on the Pod Doctors.